Welcome everyone. My name is Professor Raman Bedi and I'm the chairman of the Global Child Dental Fund, and we look forward today to a next lecture on our special care dentistry series. I want to welcome Matana Kettratad, who is at Thammasat University in Thailand. This is a really important subject area that we're going to look today because it's the practical tips that actually help us all when we manage patients with special care needs. And so we're looking forward to your lecture. And on the panel, we have Professor Callum Durward, who is the Dean of the Faculty of Dentistry at the University of Puthisastra in Cambodia. And Dr. Jacob Johns, who's Associate Professor at the Department of Restorative Dentistry at the University of Malay. Welcome, everyone. Matana, thank you so much for giving up your time, and we now look forward to hearing your lecture.
Thank you for the introduction, Professor Bedi. I'm going to share my screen now. Okay, so the title today is the tips for managing a patient with special needs. And the outline that we're going to talk about today includes the access, whether it's the design and equipment that we need for our clinic to be accessible to patients with special needs, or setting design and clinics or equipment when we go out to provide care outside the dental office. And then we are going to talk about the safe transfer and positioning of the patient to prevent aspiration, to reduce spasticity, or to reduce the pressure sore. And we would have a little bit of time at the very end to talk about some tips on managing medically complex patients. So when we talk about a design of a dental clinic, there are 4 issues that I like to emphasize. First one is quite obvious, a universal design, how to make our clinic accessible to everybody. Okay, but the second one is the healing environment, whether it's be the part of a spiritual support, the part about making it warm and making it less like anxiety or threaten to the patient. Okay. And the third one would be how to make it dementia-friendly environment, because we have more and more patients with cognitive impairment coming to see us. And the last one, how to make the clinic ready for the COVID-19 era. But before the patient comes to our clinic, as a dental professional, I think we should be also an advocate to have public transport or something similar to provide better access to care to the patient as well. And once they are in front of our clinic, the specification of universal design starts since the parking lot, and the angle of the ramp, the shape of the handrail, the size of the door and how it's open. Also, you can find like standard of this specification of universal design online. If you have some equipment extra to help ease the access of the patient with special needs, that would be lovely. And also, once you are inside the clinic, I think at least one dental unit, if you have many dental units in your clinic, at least one unit should be not just wheelchair accessible, but also accessible for a stretcher. And this is what it looks like at our hospital. We try to have it as spacious as possible. For the hallway, 2 wheelchairs has to be able to go across each other. And then you can see that we're lucky that we have the greeneries, the trees outside our window. But after the pandemic, we have to have a big renovation. The same clinic is now turning into completely isolated room with a negative pressure operating area and a positive pressure waiting area. This is another clinic at the faculty side, not at the university hospital side. There are some tips on the waiting chair. The waiting chair has to be not too high, not too low and not too high. If it's too low, it will be difficult for the patient to get up. And there has to be an armrest so that the patient can help themselves to go up. And the cushion has to be not too soft. If it's too soft, it will be too difficult as well. And we make sure that stretcher can go in operating room. And for the dental unit itself, we prefer the cart type so we can move around instead of the arm type of the dental unit. This is another example from Japan. You can see that this is a cart type that we can move it around. So if the patient come in a stretcher, we can still treat the patient in the stretcher as well. And the dental unit as this, either is 4 hinge or 5 hinge is okay. Right? I'll let you know later why it's better than the typical dental chair. And there's some, you have to provide some areas to storage the wheelchair. In Japan, they just have enough space to put the wheelchair at the back of the cabinet. In Stockholm, in Sweden, they have this just small corner, and they put the curtain around, and they put a wheelchair of every patient inside that curtain area, so it doesn't get into the hallway. And this is one of the fire code as well. Also in Stockholm, this picture shows also the healing environment. You can see a fish tank, you can see a picture, the photos of the nature and the use of the color. The high contrast is usually very useful for older adults in general, but also very, very good for the patient with cognitive impairment. So you can see that the brain can be directed into the area that you want the patient to be focused on. And also you can see that there's an armrest for the chair, and the cushion is not too soft. This example of the washroom, of the bathroom, use high contrast color for patient with cognitive impairment. And you can see the mirror here. There's a blind at the mirror in these two pictures, because in the severely cognitive impaired patient who cannot recognize their own reflection, and then they are afraid of the picture on the other end of the mirror. So sometimes we have to put the blind down so that it doesn't scare the patient. And follow standard specification of universal design of the washroom. Okay. So now if we want to go outside our dental office to see patients in the hospital, whether it's just normal inpatient wards or ICUs, we go see patients in long-term care facilities, or we visit them at their homes. Okay. So what should we provide? There's a study from Taiwan say that there are 2 main reasons that people are not willing to go out to see patients outside of the dental office. The first one is the complex medical history of the population. And the second issue is the dentist's unfavorable working condition that they said is outside their comfort zone. So how to overcome these 2 barriers? The first one, try to get the medical history before you see the patient. When I was in Canada, the clinic manager would call the nursing homes or the patient's next of kin to provide just paper-based photocopies of the medical records of the list of medication. You can have a print referral letter, but now I think I've graduated for a long time, but now mostly we don't even have to use paper-based photocopies anymore. So it comes in a photo or document file that the patient can show us from the smartphone. There's also some papers published about other information prior to the appointment besides the medical history or the list of medication. Because of COVID pandemics, we can get as much as possible information. So you can do actually the part of the dental consultation by phone or by other mobile apps, get all the chip complaint, get all the like history taking done before the patient comes. So we make sure that the patient have to come on site, or we make sure that we go to see them, and when we have proper information, we prepare all the equipment that we need. And there's an example from the UK. The National Health Service has launched a red bag project. So every resident in nursing homes, in long-term care facilities, has this red bag that includes the list of medication, all the past medical history, and this is about 2 pages document of like identity of the patient, what they like, what they don't like, what they like to be called, their former like the history of their life in 2 pages, which is it helps a lot. And even though we don't have like electronic link of database, we can also use the example of the NHS red bag scheme as well. So when they go to the hospital, to the emergency room, they bring the red bag. So similarly, when they go to see a dentist, they can bring the red bag. Or when we go to see them at their home, we can have this red bag open, and then we have all the information that we need. Okay. And this is a paper published recently about what kind of information we can get beforehand, before we actually see the patient in person. Okay. So it also assesses the risk, the vulnerability of the patient for getting COVID-19 as well. So we can weigh the risk and the benefit of seeing the patient in person. Okay, so what to bring? I'll show you in some of the pictures following this slide. The portable mobile unit right now is just a suitcase, and it can provide all type of dental care. Like they even provide like ultrasonic scaler within the suitcase as well. So it's very convenient, much better than before, that we had to carry like a big mobile unit around. Okay. When we go out, sometimes we have a designated room in a nursing home, whether it's a meeting room or like a room that they provide for rotation of eye doctors, for dentists, for podiatrists that can use that particular room. Or we can go out and about to patient's room or to patient's home as well. Okay. So following this slide, there will be examples from Canada, Sweden, Japan, Thailand, and also in the US. So the first model is to have the van or a car. At Thammasat, we also have like a pickup, much smaller than the one that Iowa has, but also with 1 unit, dental unit as well. In Stockholm, in Sweden, they use this mobile dental unit, fully equipped, just like 1 suitcase, and they have another suitcase for portable X-ray, okay, with the shield around the tube. And they go see the patient in the nursing home to the patient's room. Some example from Canada and from Japan, and also again from Sweden. If you see the patient in the hospital, sometimes you just need like a basket or a bag, and inside, I like to emphasize that it's very important to bring oximeter. Oximeter will help us to measure not just purely oxygen level, but also if the oxygen level drops more than 3%, that means the patient might have a chance of aspiration. So we can stop all the activities with the patient and then assess again whether they need help or not. Okay, and this is the mouth mirror with LED light, so we can change the tip, disposable tip, and we clean the shaft, and then we can use it for the patients that we see. Extraction, dentures can be done in the hospital bedside. This is in Thailand. We are lucky that dentist is part of the primary care team, so we usually go visit patient at home with either a nurse or a physical therapist. And we just have a basket, 2 baskets, one for the clean equipment and another one for the red bag for the dirty equipment and waste. So that's the end of the how to ease access for the patient. And the second part is once you're in our hospital, in the clinic, then what would be the safe transfer from the wheelchair, or how to position the patient to be the safest way. The gold standard is the ceiling lift or ceiling hoist, which helps not just the patient, but also helps the care provider as well. So it looks like this with the hydraulic function, just up and down, left and right, that's all. And this is the chair, 4 hinges or 5 hinges. There's a ceiling lift and there's also like portable lift as well. But if you don't have that, like in Thailand, we have it in Thailand, but it's very expensive. We have used something similar concept, but with manual lift by people. But we also use the same technique with like a cloth thick enough to wrap, and the cloth are prepared by the physiotherapist. Some comes with handles already. So this is quite a safe transfer. If the patient can still bear some weight on their feet or their foot, the gait belt is another way. But the physical therapist said just some kind of belt, any kind of belt would be okay. Or even a big piece of cloth that you can wrap around the waist. The tip is do not let the patient put their hands on your neck. It will hurt your C-spine if the weight comes too abruptly. So try to use the shoulder or scapula when the patients try to hold us. And also with this type of chair, you can see that the patient can actually transfer themselves if they can bear weight on their foot or their feet. Okay? Even if they are hemiparesis, only one side works, still with this type of chair, it's a lot easier for them to transfer it. There are some turntable to transfer the patient as well. And if you know that this visit, you're going to make just oral examination and no drillings, no scaling, like no other treatments, and you have enough space behind your dental chair. Most of the dental chair headrest can be flipped into the other side, and you can just move the patient's wheelchair and then use this headrest as the head support for the patient to do oral examination. And it can still be close enough to the dental suction. And if the patient comes with a reclining chair, a jury chair, you don't even have to transfer the patient. You can do the treatment within the reclining chair with the head support. So the head support is the most important part. If the patient comes in a stretcher, make sure that you get yourself with the right ergonomics position when you work as well. And do not place the stretcher right next to the dental chair. Have enough space for your assistant to go in to stand between the dental chair and the stretcher. So that way you can work properly without having to like stretch yourself too much or bend yourself too much. Okay? And if the stretcher makes the operator and make the operating area far from the usual place, then you have to extend your dental suction with a latex tube. And then everything will work just fine. Some patient has a problem with their like secretion and sputum. So if your clinic has this portable suction extra to the dental suction, that would be nice. Or if the patient has it at home, when you phone them to confirm the appointment, also confirm that please also bring the portable suction with them as well. Okay. So the position to reduce the risk of aspiration is to recline the chair 30 to 60 degrees. Always have the cervical neck support, okay? And provide enough time for the patient to rest and make sure that the patient is well awake. If not, then there's a risk of aspiration. You have to be more careful, especially when you had patients sedated. So you can see that supine position is not recommended. So it has to be with the back support and with the head support. And the reason is just normal gravity. The trachea, the air pipes in front, right? And the esophagus and the pipe for the food is at the posterior side. So we tilt so that if there's something go wrong, then they would go into the right channel. Right? And in patient with heavy paresis, try not to move the head of the patient, but if you need to do it, move it to the affected side, to the weak side, so that the strong side can work properly. Some of us tell the patient to tilt their head so we can see for visual, better visual, if we want to prep the tooth or if we want to clean the tooth. But if we tell the patient to tilt their head, turn their head into the strong side and let the weak side open, it will increase the risk of aspiration for the patient. Okay. So when to recline 30 degrees, when to recline 60 degrees, it's all about pressure sore. If the patient doesn't have pressure sore, then you can recline like at 80 degrees. But if the patient has pressure sore, the standard position would be a semi-Fowler position or 30 degrees. The type of dental chair, the 5-hinge or 4-hinge, is recommended also because of the spasticity of the neurologic defect patient. They would have more spasticity if the legs or the arms are stretched out because of this stretch reflex. So if it's elongated, it will show more strength, more reflex. So we want the patient to be in the position similar to this picture. Okay, so have the arms closer to the body, the side of the body, and put the arms with the support, all arms and hands with the pillow support. And do not lie like supine if you are not like tilt properly. If you are sitting down, if your legs are not straight, it will reduce the spasticity. So you can see for patients who are frail, whether it's spasticity or hypotonia, have cushion to help. Okay, to eliminate the spasticity. This is a picture from Sweden. So there's a cushion that you can clean properly with just like KB wipe. So you can reuse it with another patient as well. So it's water repellent. And have the so no straight leg like dental bed. Just have the knee like this, like they're sitting. Have the foot support, and it will reduce the spasticity of the patient. Okay, so many boost posture and make sure there are other factors involved, like whether they want to go to the washroom or not. Is there any pain, stress, fatigue, infection, or some problem like ingrown toenail would also increase the spasticity. Too tight of the cloth, or being too cold, too hot, high humidity, all these combined will trigger the spasticity as well. So we have to reduce all this with also maintain a good posture. With patient like post-stroke or Parkinson, they would have medication to reduce spasticity and rigidity. So make sure that the patient takes the medication before, or for us to make sure that the dental appointment is at proper time that the medication is already kicks in. Normally, the anti-spasticity medication will take only like 10 minutes, 20 minutes to kick in. But for Parkinson, like rigidity and tremor, it would take about an hour and a half to 2 hours to kick in. So if the patient take the medication at 8 in the morning, then you would make appointment at 10 in the morning, for example. Okay. And some patient cannot just lie down on their back. They have to tilt a little bit, but make sure that they don't put the weight onto the shoulder too much. Okay. Always have cervical pillow, the neck pillow. Okay. This patient has dementia. So when we tell them to lie down, they don't lie down. When we recline, like when we get the chairs up, right? They just get away. And when we recline the chair down, they still do not lie down. So we have to have a lot of towels and pillows and to set the position like this. This is another trick for patients with cognitive impairment or psychological problem or with a lot of anxiety. To reduce the anxiety, in Sweden, there's a clinic for homeless and psychiatric patients. This is a doll, a puppy doll with, you can put the battery in. When you turn it on, it breathes in and breathes out. So they put this doll on the tummy of the patient. So the patient holds the doll, and then the doll breathes in and breathes out, just like the real puppy. So it is the anxiety for the patient, and it reduces the spasticity of the patient as well. Okay, so this is the last part. There are some tips on some type of medical complex patient. Okay. If the patient do not open their mouth, how can we open their mouth? Okay, first, desensitization. Like you massage the TMJ, you massage the cheek, you massage under the lips or the lips, and then the patient feel more relaxed. They know that something is going to touch, like we're going to touch them. So they won't get too like excited. Now you put your finger, retract the lips, retract the buccal, and then you go into like behind the tuberosity, and then you tilt your finger, and then you press what's called K point, which is found by Professor Koshima in Japan. It's a reflex point for jaw opening and swallowing. But right after they open their jaw and they swallow one time, they would close their mouth again. So you would need something for the patient to bite onto. In all the guidelines in special care dentistry, they recommend this open wide mouth rest, which is a foam, like EVA foam with a thin layer of wooden in the middle. It's soft enough, it doesn't hurt the jaw and the tooth. If you place it properly, don't place it on the front teeth, place it like on the posterior teeth, and it's soft enough and it's strong enough so the patient cannot destroy it easily. Okay? If for mouth prop, I don't really recommend if the patient has like behavioral or psychological symptoms. They would chew multiple times, and they can also choke on this mouth prop as well, even though you have the floss with it. You have to fight with the patient, and if they are like difficult patient cannot open their mouth easily, then there might be some incident. And with the mouth gap, patient with cognitive impairment, they don't like the mouth gap at all because of the handle that would place on their cheek. And also, once we already open, if the patient bite down multiple times, it doesn't really work. So mouth rest would be the one that can hold the strength of the bite. And always have oximeter. And if the patient has high blood pressure, monitor the blood pressure by having the cuff all the time during the treatment, and you measure it every 10 to 15 minutes. Patient with dialysis, they would have a shunt vascular access on their arms. So do not measure blood pressure on that side of on that arm. In many countries, they would wear a wristband, but like in Thailand, we don't have a wristband for them yet, so you have to be very careful. Like sometimes the children of the patient is waiting in the lobby, and the patient come into the room alone, and they don't they follow every command. So sometimes they don't tell us that they have this vascular access on their arms. For Parkinson's disease, now there are more and more people getting this deep brain stimulation placed. The good thing about this machine is that you can turn it off. So if you turn it off, you'll be safe. But if you don't turn it off, the heat can burn the brain. The heat from all this equipment that we use in the dental clinic. So it's like fatal. It's very dangerous if you don't turn it off. But if the patient has this DBS placed only like less than a month ago, you have to consult the physician to titrate the anti-Parkinsonism medication before you turn off this machine, so that the medication is at the level enough to control the tremor and the rigidity of the patient. Different from the deep brain stimulation machine or the implant device related to heart problem, you cannot turn it off. But now, about 10 years ago, I think the development of this device has improved a lot. They have a like titanium shield. So when I was in undergrad, we were taught not to use so many things in the dental clinic if the patient's on pacemaker or like any implanted cardiovascular device. But right now, I think the shield of this device has improved a lot. But to make sure, they would have a card with them, and this card would tell the model of the device, would tell the day they had it implanted, would tell all the details of the model. So you can look up. So now you can just Google and look up whether this model is compatible for using apex locator, ultrasonic scaler, or just normal drilling. Okay, so it depends on the model and how long they have it placed. Just look up the details online. Now it's very convenient. And if the patient has medical emergency, and even though they have osteoporosis or osteopenia, make sure that you use the same CPR protocol, because if you don't press deep enough, you won't get into an aorta, so you cannot help the patient. But be careful with the red color area, which is the costal cartilage that is usually like calcified. So you can break that red area. But if you place your hand in the according to the CPR protocol, just use the regular protocol, even though the patient has osteoporosis. And at our school, we try to teach them about how to ease the access of the patient. So we invited instructors from Faculty of Architecture to teach us how to proper design the ramp or the interior of the clinic. We invited instructor from physiotherapists to help our students learn how to proper transfer the patient from wheelchair to the dental chair. We also invited the critical care nurse to help us teach how to take care of people with ventilator, the chest PT to help us how to do, to clear the lung, the patient aspirated. So this is it. So this is the picture of my two patients, specialist patient, but they can take very good care. Their caregivers can take very good care of their team. So welcome any questions, and I'll answer. Thank you.
Good, Matana, thank you so much. That was a great lecture, really insightful, and really lots of very good tips and advice. I'll just hand you over to our panel for any comments or questions. Jacob, I wonder whether I could start with you.
Thank you, Professor Raman. Thank you, Dr. Matana, for the wonderful lecture, and very insightful and very explained. You have gone through every equipment that is essential to care for a special needs patient. Thank you for that. Just would you like to touch on how, as a general practitioner, dental practitioner, if we are called to look into a palliative care patient, is there any protocols for that?
Okay, yes. So palliative care patients, we can be part of the team, and we can help a lot with the comfort of the patient to reduce the pain. Usually, we don't have to do like the pain. They have the pain ladder, how to manage the pain. So that would be in charge of the palliative care team. But what we can help from my experience is how to do how to fight the dry mouth. Because the dry mouth is the really pain, like is the important part of patient at the end of life, that they suffer a lot from dry mouth. And if we are not going to step in to help, they would usually try to sip some water or suck on the iced cube. But then if they have also aspiration or dysphagia, swallowing difficulty problem, they would aspirate all this liquid, and then they would have to cough it out, and then that would increase a lot more suffering for them, like lower the oxygen intake, and then they will feel like very tired from all that aspiration. We can help them with this, like like saliva substitute, and help with the cleaning the mouth, and also reduce the infection, not to cure them, but just to lower the pain and increase comfort. And in cancer patient with the tumor, like head and neck tumor that's not properly treated, actually we can help like prescribe metronidazole gel, or just like put it out from the capsule and place it on the tumor to reduce the smell of the tumor as well, to reduce like all this anaerobic bacteria, and also help with the work with the palliative care team for the pain control.
Good, lovely, thank you. Callum, over to you.
Thank you, Dr. Matana. That was a very nice lecture. Sometimes students and dentists worry when they put their fingers into the mouth of some special care patients, they worry that they're going to bite their finger. And what have you found over the years that has helped to avoid having your fingers bitten?
Okay, so if we look up into some guidelines recommend like a silicone or plastic cover your finger, but I don't really like to use it because it's not, you cannot go like deep into the mouth. So what I do is just be quick and use this try to retract the lips and the buccal mucosa out, and use it open wide mouth rest. So the mouth rest helps a lot, and
Yes.
you won't get bitten easily. And if the patient is needed some oral sedation, so then you would prescribe oral sedation before seeing them. Okay.
Right. Thank you.
Thank you.
You're welcome.
One more question. How do you think about the use of ART, atraumatic restorative treatment, with some of these patients, especially when you might be visiting them at home, for example?
Yes, ART is very useful. I think it's globally accepted now. So we use a lot of ART technique, whether it's with or without drilling, but we use a lot of GI. And also combination with silver diamine fluoride as well.
Okay, thank you.
Okay, that's really helpful. And I think Thammasat University is the global center for the Silver Smart, with all the work that was being done by your former dean.
Yes.
Okay. Can I just ask you about training? For me, special care dentistry is very much about training the whole team working together. And I just wondered whether you could just give us some insight into how you undertake training. Two particular areas I find as useful. One is lifting the patient, either with a hoist or just lifting them up. The team have to all know what to do without causing a problem. And the second is a common problem is choking. dry mouth, dysphagia, water in the mouth, all that can often create choking. And again, I think the team need to know how to react to that. I wonder whether you could talk about training of your team and particularly how you would take those two situations.
Okay. The training of my team. So my team right now would be like grad students and also dentists. But so we got proper training from also physical therapists, from the rehab physicians, and also, but for the undergrad level, they just know the theory, but they don't get to practice. They get to practice only transferring patient, but they don't get to practice like how to do chest percussion, that kind of stuff. But for postgrad, so we teach transferring patient with or without a hoist, and also we teach like proper chest PT management, and also we train with the rehab physician on how to prevent aspiration as well.
Okay, no, that's really, really helpful. I think training and working as a team is one of the key aspects. Jacob, Callum, is there any comments or further comments or questions you would like to ask?
Not from me, thank you.
Okay.
If you don't mind, Prof. Raman, Dr. Matana, you spoke about domiciliary care. Now, is there any special informed consent aspects that we have to look into when we are doing this kind of a service, from the informed consent that we get from the patient or the family?
So whether it's on site, like at the clinic, or domiciliary, I think the informed consent would be the same thing. But this is like cultural issue as well. I'm not sure in Indonesia or in Malaysia is the same, or in Cambodia is the same. But like for Thai people, consent is not like, doctors still has a lot of authorities, which is not a nice thing, but we do, and the patient do not actually care much about written consent, but we do get verbal consent, and whether it's at the clinic or whether it's at home, is autonomy of the patient is key. So we always have the verbal consent.
Okay, good. Well, it's been really entertaining and so thoughtful. The lecture was really helpful. So I want to thank our panelists, Professor Callum Durward and Dr. Jacob John, and our speaker, Matana Kettratad. I'll get that better as pronunciation. But Matana, thank you so much. It's been really kind of you to give up your time and to give us this lecture. And with that, we'll draw to a close and we'll say goodbye to everyone. Bye-bye.
Thank you.